Good afternoon. Welcome to the TBI Treatment Trends Meet the Author webinar. I'm Dr. Roland Gerritsen van der Hoek, Chief Medical Officer with Zenith Critical Care, and on behalf of my colleagues, I want to thank you for your attendance. All traumatic brain injury treatment, apart from emergency neurosurgical intervention, is currently limited to supportive care. That is care that addresses the cascade of physiologic and cellular events that can lead to extensive additional neuronal death and subsequent loss of function after the initial trauma to the brain. Despite decades of research and more than 75 clinical trials, there is no treatment that has been proven effective for acute TBI in placebo-controlled studies. Notwithstanding that, a number of measures are widely recognized as an essential part of the accepted standard of care as codified in the guidelines by the Brain Trauma Foundation. But not all physicians are in agreement on the efficacy and role of these interventions in treatment outcomes. Interventional treatment based on intracranial pressure monitoring, or ICP monitoring, is one such measure. TBI expert Dr. Chesnut, the lead investigator of a group that examined whether or not treatment based on ICP monitoring is an effective TBI treatment intervention when compared to interventions based on clinical symptomatology and imaging. The results of their study, a trial of intracranial pressure monitoring in traumatic brain injury, was published in the New England Journal of Medicine in 2012 and calls into question the value of ICP monitoring as the basis for treatment decisions for improving TBI treatment outcomes. As you might imagine, this finding generated a great deal of, shall we say, passionate discussion immediately upon publication. And that discussion continues to today. We are honored that Dr. Chesnut is here today to discuss his thought-provoking study findings and answer your questions. Before I turn over the session to Dr. Chesnut, let me take care of a few housekeeping items. We welcome your questions about any part of Dr. Chesnut's presentation. And you may pose questions by hovering over the green tab at the top center of your screen, then click on the Q&A button, type your question in the box. Please make sure that it's addressed to all panelists and hit send. All questions will be captured, and we will attempt to have Dr. Chesnut answer all of them during the question and answer session immediately following his presentation. In order to provide Dr. Chesnut an opportunity to present his findings without interruptions, he will answer your questions at the end of the webinar. If you experience any difficulties during this session, please use the Q&A box to contact the WebEx producer and ask your question. So one more time, at any time you may pose questions by hovering over the green tab at the top of the center of your screen, click on the Q&A button, type your question in the box. Again, please make sure that it's addressed to all panelists and hit send. Do not use the chat tab as it will not work. And now it's my great pleasure to turn the program over to Integra Andout, Professor of Neurotrauma, Departments of Neurological and Orthopedic Surgery, and Adjunct Professor, School of Global Health, Harborview Medical Center at the University of Washington, Dr. Chesnut.
Thank you very much. Can you hear me? Okay.
Yes,
can you all hear me, I suppose? Great.
Yes,
okay,
we can
well,
hear you.
Let me get started here. I'm going to be talking about improving outcomes, severe traumatic brain injury through international research, which this particular effort was on intracranial pressure monitoring. And following this study, for which there were a lot of comments, with or without having actually read the paper, we were certainly in line for a lot of interesting questions and controversy, sort of as if we had gone to the dark side. So I want to clarify things here, because as usual, it's about definition and what we actually tested in this study. And that's with which I'll spend some time with you. I do apologize if in the background you may hear a siren or a helicopter once in a while. I'm at one of the busiest trauma centers in the U.S., and this is reality. But I do have a couple of disclosures. I received an honorarium connected to the presentation. I'm the Integra Endowed Professor of Trauma here from the Integra Foundation, and this presentation reflects my thoughts. Well, intracranial pressure is the cornerstone of the critical care of TBI, as you heard during the introduction. Most of us believe that severe traumatic brain injury should not be treated without monitoring ICP, and indeed most of us in modern academic medicine have never treated a severe traumatic brain injury patient without ICP monitoring. So when we set out to write the guidelines in the early 90s, we set out to prove that ICP monitoring was mandatory. And when we actually looked at the literature, however, we found there was no class 1 evidence, very little class 2 evidence, and really only class 3 evidence. And that surprised us and was disappointing. So we felt obviously there was a need for a class 1 study, but for ethical reasons, since none of us would be comfortable with a non-monitored control group, we felt this study would never be done. Well, as we started to do research in Latin America and outside of the high-income, resource-rich countries, we found that wasn't necessarily true. There were a lot of people in the world who weren't monitoring external pressure and would like data as to whether or not they should, both for medical reasons and resource allocation reasons. So equipoise actually did look, and so that was the origin of the study that we did in Latin America to look at the influence of intracranial pressure. There was 2 hypotheses. One was that the ICP monitoring group had significantly lower mortality and better neuropsychological and functional recovery at 6 months. And 2 was that using ICP monitoring would minimize complications and decrease length of stay in ICU. This was a multi-centered, randomized control group of patients with severe traumatic brain injury, Glasgow Coma Scale score on admission or within 48 hours of less than or equal to 8. And it compared 2 treatments, one driven by ICP monitoring and one driven by imaging and clinical examination without the use of intracranial pressure monitoring. So intracranial hypertension was treated in both groups. Primary outcome was a composite outcome score at 6 months, and it was an intent to treat analysis. So we analyzed people as allocated. These were trauma centers, busy trauma centers in Latin America with 24/7 intensivists, all members of the Latin American Brain Injury Consortium. Neurosurgery was available 24/7, as was CT imaging. And they were at equipoise to the value of ICP monitoring. They had it available in terms of ventriculostomy, but it was actually rarely used, and we believe they were truly at equipoise. We did this study in Bolivia and Ecuador, 4 centers in Bolivia and 2 in Ecuador. All patients were studied. All patients who consecutively presented were randomized, or were screened rather. Inclusion criteria were based on the Trauma Coma Data Bank, published in the early 90s, really the reference study for most of our treatment nowadays. The exclusion criteria were bilaterally fixed and dilated pupils with not moving to stimulation, not expected to survive for other injuries, and then there had to be ICU beds available and an ICP monitor, a study ICP monitor, a parenchymal ICP monitor, had to be available. All patients had at least three CT scans of the brain at baseline, 24 hours to 48 hours, and then 5 to 7 days. Other CT as needed. They had standard supportive care and aggressive management of general non-neurologic intensive care. And patients who were randomized to monitoring had an intraparenchymal monitor placed as soon as possible within the ICU, and they were treated at an ICP target of less than 20 millimeters. Now, the algorithm for treatment patients with monitoring was easy. We could take it out of the Brain Trauma Foundation guidelines. That's well circulated. The treatment for the patients who were not monitored was actually a problem, since there are no published algorithms for that group. Again, those of us in high-income countries tend to monitor, and we're the ones who publish. So we got together our principal investigators who actually do this every day, treat without monitor, and we used a little bit of Bolivian Paseña beer and some time at the poolside, and we came up with an algorithm that they agreed to follow that met their treatment approach. It's actually a relatively simple algorithm, but it's called the ICE protocol, the Imaging and Clinical Examination. It's based initially on the admission, CT, and examination, and whether or not the patient was felt to have swelling. The treatments were the same ones pretty much that we would use with a monitored patient, and these were modified or changed or eliminated over time based on serial examination and sequential CT scans, at least at 48 hours and at the 5th to 7th day. Obviously, any change in exam or at the discretion of the physician, the treatment algorithm could be modified just out of good clinical medicine, and that held for both groups. The general treatments were mild hyperventilation. That's actually what they were doing, corrected for altitude. Now, I know that's somewhat controversial, but they derived the treatment. They're the experts in non-monitored treatment. So we have no data on whether it makes a difference, so we followed their algorithm. At that time, when we started this, mannitol was the hyperosmolar treatment of choice, and this was given via an infusion on a scheduled basis, lasting out to 6 days in a taper fashion. Hypertonic saline could be used, and actually became more used over time in that group. Now, note that this is a little different than most of its uses. This is fixed schedule over time. It is not bolus for an intracranial pressure spike because they don't monitor. And that may play a role in interpreting the data. There was a neuroworsening protocol for all patients. Any patient who showed any signs of deterioration had a strict response algorithm, and it had to be noted by data in the chart that they had changed the treatment within 1 hour. So that was our QA loop for that, and it was actually very well followed. Outcome was measured at 6 months primarily, including mortality, VOSE, disability rating scale, and a number of neuropsychological assessments put together and mathematically massaged into a composite score. The 6-month outcome was independently evaluated by outcome examiners who were blinded to the primary treatment. It was given in their primary language, primarily Spanish, but in some cases Quechua or Aymara. Now, this is a little different than using the standard QOSE, but this scale is actually more sensitive to the middle group of outcomes, and because of its sensitivity, required a lower number of patients for the same power of the study. The primary outcomes were obviously mortality and complications. The secondary outcomes, the pre-specified one, were total ICU length of stay, and then the duration of brain-specific treatment, which excluded mechanical ventilation, sedation, and analgesia, because those are sort of just the cost of going to ICU. Those are not really brain-specific treatments, and we were looking at brain-specific management. And then systemic complications, post-hoc additional secondary outcomes were numerous: ventilator days, high-dose barbs or decompression, et cetera. Now, our definitions, as I said, were somewhat specific. They did not include mechanical ventilation, sedation, and analgesia in the specific calculations because those are commonly applied for non-neurologic causes. Brain-specific therapeutic intensity level was just how many treatments the patients would get every hour, with each treatment given a single point. Brain-specific treatment duration, how much time elapsed during which the patient received one or more brain-specific treatments, and then the total number of brain-specific treatments over the entire course. What were the results? Well, our consort flow chart found that we were able to randomize 60%, 61% of those who were potentially randomizable. When we compared the two groups that got in and didn't, for reasons of consent, refusal, no beds, they were not statistically dissimilar to the group that got in, and we had very good follow-up. Our outcomes people were real heroes in tracing these people down. Our primary pre-specified outcome of composite score, as well as mortality and VOSE, showed no significant difference between the groups. This is our Kaplan-Meier mortality chart, and again, there was no significant difference here. So in total, the primary outcome of the study revealed no significant difference between the groups at 6-month outcome. We went back to some post-hoc analysis. When you look at the primary curves, you find they seem to be the widest apart at 14 days, still in ICU, and we thought maybe that was a more sensitive indicator, but when we did that, we found that at that time, again, we found there was no significant difference between groups. We went back and looked at every single individual subscale within the study to see if any of them suggested a difference between groups, and they didn't. Every one of them showed no difference between groups. So we don't think we missed any trends or neuropsychological outcomes within this analysis. When we looked at some of our secondary outcomes, our pre-specified secondary outcomes, ICU length of stay of brain-specific treatment, we found that there were 1.4 days fewer if you were ICP monitored, statistically significant difference. Post-hoc analysis, we looked at the total number of treatments delivered over the entire course, And again, we found a statistically significant difference between the groups, with about half as many treatments delivered if you were monitored than if you weren't. So in general, the implications are that the two groups, as defined and as treated, had equal 6-month outcomes. ICP monitoring was associated with more efficient treatment, 50% fewer treatments, 1.4, 29% fewer ICU days. And so there was a benefit to ICP monitoring, but it did not manifest as outcome. Of course, the first thing you have to ask, what does this mean to me? This was done in Bolivia. Now, I can tell you I spent a lot of time there. These were very dedicated doctors and very good care, despite not being in high-resource countries. And so I was happy with the ICU and all of our quality indicators in the 92-page supplementary document published in the New England Journal suggests that they did a very good job and that there were a few protocol violations. Pre-hospital, there was minimal pre-hospital care. We don't know the transport times. We don't know the incidence of hypoxia and low blood pressure. We don't know how many really sick people didn't make it to hospital. We don't know how many people might have been worse arriving because of secondary insults. And we don't know if those two balanced out. None of them had rehabilitation as well afterwards. So in terms of looking at this and controlling for it, there's really no data. We didn't have an extra couple $1 million to look at those aspects. The information we were able to glean confirms these suspicions, but certainly doesn't allow us to mathematically control for these issues. So in terms of generalizability, if you're from a low and middle income country, this is highly applicable to your reality. If you're from a rich country, a high income country, then the applicability is probably phasing. In ICU, it tends to be quite high because once they reach ICU, I would say the care was very similar there as here. They did really an excellent job. But because of the pre-hospital and post-hospital variables, I think you need to be cautious. This is not directly generalizable. I think we all need to be cautious when applying these data to our own reality. It doesn't invalidate these, but again, caution is urged. One thing to note, however, now, it's most important to know, what did we test here? This is actually the crucial question. We didn't test the value of aggressive care of severe traumatic brain injury medicine. Non-monitored patients got aggressive care. We did not test the concept of treating atrial hypertension. Both groups were treated for atrial hypertension, monitored differently, but treated aggressively for atrial hypertension. And we didn't test the value of knowing the actual internal pressure because we just tested how knowing it was manifest through the treatment algorithm. There are many reasons to know it that weren't tested here. So what we did do was we compared the ICE protocol to one particular ICP-guided protocol applied to all severe traumatic brain injury at 20 millimeters of mercury. The one-size-fits-all approach that is almost globally done to ICP monitoring, but maybe now worthy of some severe questions. Because when you think of ICP, you know that there's a group that's below threshold, and we really don't treat them, and then there's a group that's above threshold. And the concept here should be is that ICP is primarily an indicator of severity of disease. And in that way of thinking, there can be low ICP as an indicator of mild primary disease, intermediate ICP, moderate disease, and high ICP generally indicative of severe primary disease. And treatment reflects this. With increasing resistance to treatment, and hypertension is worse. There's a group that responds to treatment, and there's a group that doesn't. And in general, if you don't respond to treatment, generally you have a poor outcome. There's also a group that may respond to treatment, usually very difficult and extreme treatment, who also has poor outcome. Then there's a group who has good outcome, maybe no matter what we do, but they have low ICP, mild primary disease. And then there's the group whose outcome depends on pressure treatment. That's the group that is poorly defined, actually, but who, if you don't lower the ICP, they won't do as well. That's the group we believe exists. The best TRIP trial, our trial, tested the entire group. And in that, the ICP monitored group didn't do better than the non-monitored group. The one group, of course, that we believe really is of interest and could be further studied and defined is the group where if you treat ICP and lower it, they do better. We believe they exist, but they are a subset of ICP. And there's a lot of work to come to understand this group. Indeed, what is the definition of intracranial hypertension? What's a dose of intracranial hypertension? Should be personalized treatment thresholds to individual patients or injury subtypes. Can we identify injury subtypes to treat differently? And is the patient the same on day 1 and day 3 and day 5? All of these things have been sort of disregarded over time and now come to the fore as a result of the best fit trial. There are probably patients who don't need treatment, even if their ICP is 25. Indeed, every time we scrum or climb or push uphill, our ICP is well over 20 to 25, and none of us herniate and die at that point. So there's probably points where the brain is slightly swollen because it's injured, but this doesn't require treatment. Indeed, my feeling is that any patient whose ICP can be totally controlled just by external ventricular drainage probably doesn't actually need management. They would probably do fine with good support, good resuscitation. There's also the groups who have high ICP, which may or may not be controlled, who group poorly. And we tend to think, well, it's because their ICP is so high. But it's interesting, when you look at studies of ICP treatment, and you look at the groups that were poorly controlled or not controlled, there is always a subpopulation within there who do well. So, suggesting that this is not a one-to-one relationship, and maybe these patients are not being treated correctly. There's another thing that came out, another aspect of this treatment that we didn't plan but came out of the analysis of it, and that there were really some fundamental philosophical differences between the two approaches. In general, with monitoring, we watch the ICP and don't do anything really until it spikes above 20 or 25 on threshold. Then we attack it, and we're fairly vigorous, and often we use more than one treatment, but we drive it back down so that it's low again, and then we repeat the cycle. This is sort of a crisis approach to intracranial pressure. In the ICE protocol, as you saw, we used the tapered scheduled dose approach, which really, to some extent, is more of a tranquility approach. It tends to try to keep the ICP low, but it isn't crisis management. And indeed, retrospectively, analyzing the results of this study, we began to wonder how meaningful the difference in these two philosophies is really, in terms of analyzing the data and where we go from here. It may actually be that in patients who manifest brain injury as intracranial hypertension, it might be better actual to keep them in a tranquility approach rather than management crisis intervention. Clearly, however, though, we should no longer idolize intracranial pressure. ICP is an epiphenomenon. There are a lot of ways to an ICP of 30. And each one of those probably warrants different treatment based on different identification. It takes multimodality monitoring to identify them, and they probably require different treatment. Just having the same algorithm for every patient is probably a gross oversimplification and wants changing. ICP should not be a goal. ICP is a tool. It's an alarm clock. It says there's something wrong in the head, something wrong with the brain. But just treating the ICP is basically simply turning the alarm clock off. What we need to do is to wake up and get to work to figure things out. For instance, ICP, which is generally thought as monolithic, thought of as one thing, can be easily divided at least into two aspects. Perfusion, which most simply can be thought of as variable perfusion method, mean arterial pressure minus peak pressure. And then separately, it can be thought of as herniation, which obviously we can see when the pupil starts to go oval or get big. Or we can think of a bit more quantitatively. We can look at the waveform and let's do some waveform analysis, or we can do formal compliance testing. But that's much more of a compliance, much more of a physical aspect, whereas CEP is much more of a perfusion aspect. So we can actually think when we have hypertension, what's going on? Is it edema? Is it hyperemia? I mean, it could even be hydrocephalus. So we can't just think of ICP alone, and we can't just think really of CPP or herniation. It's part of a mosaic. It's much more complicated than simply driving down this magic number. ICP is not a monolithic foundation of brain injury. It's a variable in a larger equation. And we've got to start thinking of it differently and approaching it from that if we're going to understand it. It's a compass, not a destination. So can this study kill ICP monitors? A lot of people, well, I don't need to monitor anymore. And hopefully not. ICP monitors aren't the problem. It's really how we interpret the numbers. First of all, in most studies that aren't randomized, and the studies out there like the Kremer study and the Chaffee study, there's no control over how patients were managed if they weren't monitored. And this study showed aggressive management has good outcomes, but it didn't show that if you don't monitor the patient and you just put them in a corner and see how they do, that they'll do well. So again, it's not the monitor, it's the use of the data. Well, in response to this controversy that we stirred up, we asked 22 of opinion leaders, neurosurgical and critical care from around the world to meet here in Seattle to discuss what we do from this. Where do we go now? And those are in the process of being published now, the results of that meeting. But in general, the number one research priority was to determine the definition of a dose of intracranial hypertension. It was recognized that being above 20 for 5 minutes, 10 minutes, depending on how the nurse records it, depending on how the physician interprets it, is probably not right. Area under the curve is becoming increasingly shown to be more important than the number, and we don't do enough with trends. 100% consensus that a critical step in taking ICP management to the next level is establishing methods to fine-tune ICP interpretation and treatment to the individual patient. So we've got to rethink ICP. It's no longer 20 for all. Where might we be an error in this? Well, obviously, there are two simple concepts of ICP threshold. And I think, some people use 20, some people use 25 reasonably. In the literature, there's all sorts of numbers, and some of the most ingenious people with whom I've ever worked. And indeed, here at Harborview, we do the same as we try to taper the threshold over time to the needs of the patient based on other monitorings. Wrong management algorithm in general, maybe we don't have the right approach, or should we apply the same algorithm for all people? And I think most of us think no. Most of us have tried to fine-tune the algorithm, but that needs to be understood better and popularized. And then the whole issue of the treatment philosophy. Is the crisis management actually the right management? That's a much bigger question, but probably warrants investigation. And then thinking of ICP in isolation, you can't just put an ICP monitor in. If the ICP is low, maybe you can. Maybe you can wake the patient up and figure out how they're going to do. But if the ICP is high, then you've got to say why. And you shouldn't just put monitors in to get more numbers to treat. That's voyeurism. What we want is people putting monitors in with the specific question of asking, is there hyperemia? Is there ischemia? And if so, how do I treat it? And if it's there, does my treatment actually make that aspect of the pathology better? So it's an investigation, and we can't think of ICP in isolation. So where do we go from here? Well, the real goal here, the challenge, is to derive a method of addressing ICP as redefined that would show a difference if we were ever to do a best trip trial too. That's the concept that I think should arise from this paper in the long run. So with that, obviously there's a lot of people to thank. There are huge teams in Latin America who did yeoman's work in doing something they'd never done before. And you cannot believe the quality of data and the effort made in tracking these people down for outcomes. So although, those of us here, I guess, get the credit, everyone was a co-author and everyone knew be recognized as a contributor to this paper. So thank you very much for allowing me to present this, and now I'd be happy to entertain some questions.
Thank you, Dr. Chesnut. Thank you for that excellent presentation. Let's now move to the question and answer section of our webinar. As a reminder, you may post questions by hovering over the green tab at the top of your center of your screen and hit the QA button. Please type your question in the box and make sure it's addressed to all panelists and hit send. While we're waiting for the questions to come in, I have one question to you, Dr. Chesnut. Have you looked at how the overall outcome in this study compares to studies that have been recently done in which ICP management of intracranial pressure was conducted according to BTF, and whether they are similar in outcome or whether the study in South America has a different outcome overall?
Yeah, we have actually. We were actually rewriting the guidelines, and nothing like a randomized trial to show all of the warts in a treatment algorithm because of the rigor with which data is collected and defined. The retrospective analyses have actually a lot of problems, and depending on how you define intracranial hypertension and apply it to your retrospective analysis, you can define your way into a number of outcomes. And I do take some issue with a recent publication from the TRACK TBI study, where they define, for instance, intracranial hypertension as one treatment for ICP and found that patients who responded did better. I think that's a problem with definition. So, I think there are a lot of issues, and I believe ICP monitoring helps people be optimally treated. But I think in general, the way we teach it and the way it's generally disseminated, we don't have it right. I still think monitoring is important, and it certainly didn't make people worse and was more efficient. But again, we probably overtreat, we probably undertreat, and we probably mistreat based on it. So I think that retrospective analyses have enough flaws that in the absence of either a very large prospective database with multivariate analysis or another randomized trial, we have to rank the data in terms of its rigor.
I have a question here from Evert Eriksson. What is the primary injury mechanism in the study population, and does this apply to U.S. patients?
It's interesting. In most low and middle-income countries, they tend to be younger patients. So this group is really does not represent the second peak of traumatic brain injury in the 60, 70, 80-year-olds that we see, at least here in the U.S. The mechanism generally is road traffic accidents, although falls were a fairly significant number. But in general, it's road traffic accidents in youngish patients.
I have a question here from Ryan Hakimi, who says, the tranquility approach, wherein mannitol is given on a scheduled basis, is refuted by many who believe that mannitol stops working after a period of time. I'm curious of your thoughts.
Well, we know that's true. We know while mannitol is running in, it can score, but the body equilibrates. And the tranquility approach is not well worked out. And that's actually some NIH-funded research that we're doing now in follow-up to the best trip trial. I wouldn't just say we should adopt the tranquility approach, and I think you do have to be careful. You're not just shooting for a raised osmolarity. You're actually probably benefiting the patient during the actual infusion. How long it lasts is really questionable. But I still think the concept that crisis management versus tranquility approach, which we didn't plan ab initio, but something that may actually be more important than we give thought to.
Well, we are asking for any more questions at this point in time. Oh, there's a number of other questions coming in. This is from Joseph Blansfeld. Did you find a difference between blunt or penetrating mechanisms of trauma in your conclusion for ICP ICUs?
This was all closed-headed. We excluded penetrating heading.
Okay, that answers that question. Here's another question from Evert Eriksson. Were serum sodium levels used in the ICE protocol or simply a standard dose of saline daily?
Serum tonicity was used, and again, that had to do with the labs that were available in terms of measuring BUN or osmolarity directly. Serum sodium thresholds were used, consistent with the recommendations of the Brain Trauma Foundation. So the same serum sodium thresholds and tonicity values were used for both groups.
Was there a sodium goal to reach, or was it a threshold
No.
of which treatment has?
No, it was sort of toxicity to avoid. It was not a goal to reach.
Okay. I'm waiting a few more minutes for additional questions. Bear with me, please. Here's another question coming in. Go ahead, Dr. Chesnut.
No, I think the ICE protocol was basically a small group consensus approach derived from the way that these people were treating traumatic brain injury. And if you look at the literature, there's no guidance. I have no idea how you come up with these treatments, but this is what they've been doing for a long time. And so that really made them the experts, of course, only at an anecdotal level. So we didn't inherit, we adopted the treatments that they tended to use as various groups. And that's where it comes from. This is not what we would have necessarily derived, but the truth is we were all ignorant. I don't think I've ever taken care of a severe traumatic brain injury in my life without an ICP marker. So I am not an expert about it.
I have another question here from Ryan Hakimi. An interesting thought related to your study is that it potentially supports the thought that sedation vacations for frequent clinical examination may be useful in guiding management and ultimately affecting outcomes. Do you have comments on that?
Of course. That's a bit of a sticky. I don't like scheduled sedation vacations because I think there are times when the tranquility approach works. If you're really struggling with ICP or perfusion or something, then I tend not to use sedation vacation. On the other hand, your most valuable monitor is really your nurse, who can tell you how the patient behaved overnight, what happens when they lightened up, what happens when they were turned or suctioned or managed otherwise when they were stirred up, if the ICP came down quickly. She can usually tell you information that tells you about the compliance and about the actual ICP course much better than looking at a few numbers. And I think that the exam is way undervalued. I absolutely believe that, if a patient comes in, diffuse injury 3, swollen brain, and you're worried about it, you put an ICP monitor in, or ICP tends to run 24, 25, and you're using the threshold of 20. Well, the first day, you probably try to keep them down. Good idea to manage everything and get a good feel for the patient. But then along, say, the second day, or say 36 hours now, you're giving them once in a while some hypotonic saline, you're keeping them sedated, you're keeping the PAC2 at about 35 to 37, and then you lighten them up, and they follow from in. And you notice that when the ICP goes up, it comes down a bit with sedation. That patient may well be one you should say, okay, well, let's raise the ICP threshold and wake them up and extubate them. And that's the kind of information you can use to understand the ICP value and the ICP trend. So I really believe the exam is way undervalued and very important. I do think you have to be a little cautious, not to set yourself back by stirring up a patient who would be better maintained sedated for a while. So I agree with them. It's very important, but again, it needs to be well thought out when evaluating.
I have a question here from Alex Axelred. Is there a difference between CPP monitoring, Lycox oxygen tension, and brain metabolic rate regarding survivorship?
Well, that data didn't come out of this study. We think there is. Sometimes the metabolic rate is a marker of disease severity, and sometimes it's manipulable. It can certainly be manipulable to try to optimize the balance between delivery that might be limited by edema-based diffusion distances, et cetera, and metabolism, which you can manipulate. Metabolism again is a marker of disease severity and also a manipulable entity. CPP is basically a proxy for flow resistance and a sort of very indirect proxy for flow, but flow has nothing to do with metabolism. So if you want to get into metabolism, you should measure it or index it. You can do it indirectly with like EEG, et cetera. You can do it more directly with flow probes or CT perfusion, which is indirect, or TCD, which is not indirect, but non-continuous. Or you can try to look at the balance of perfusion and metabolism very focally with all its limitations, such as with the Lycox, or more globally, but incompletely with jugular venous saturation, or again locally with dialysis, et cetera. And those are questions I think you should use specifically when you're trying to figure out the pathology, recognizing the limitations of the individual monitors and cross-checking them, if you will, looking at matching flow patterns to areas you think might be at risk for ischemia. And that's multimodality monitoring, and that really suggest how we should understand the pathology underlying intracranial pressure.
Here's one more question from Evert Erickson. Do you know the average transport times for the centers used, and how many patients came in by car or ambulance, or even by more modest means like horse or cart?
Well, no, I mean, patients come in by JAMA. That is a black box or gray box in Latin America and in most low and middle income countries. There's no run sheet. There's no ambulance driver that has to fill out a run sheet to bill for the service, which is how we've made the pre-hospital care providers document pre-hospital situation in the U.S. So we don't have the benefit of that, and unless you put someone 24/7 in the ER, waiting for each patient to come in and then running out and asking the person transporting that patient some questions, you can't collect the data. It was a real problem. We wanted to, we tried to, but it's a whole separate study to look at that pre-hospital situation. So we honestly don't know the transport time or the number of secondary insults. I can tell you, though, 40+%, 40-ish percent came in by quote-unquote ambulance, but that's not the same kind of ambulance that we have in use here. That's an ambulance that's basically bringing in a patient. So they didn't get the same care. And then the rest of them were brought in by other means, often private vehicles or taxis, really with no pre-hospital care. So the issue is we suspect that there was more pre-hospital secondary insult, which would have made the patients worse. On the other hand, it's probably true also that the more severe or the most severe patients may not have reached hospital. So there's a bit of a balance here, and we can't quantify it. So we will readily admit this is a poorly quantified aspect of this trial, and it influences the generalizability of the study. But and that's something that needs more investigation. The only thing to realize, of course, is that it affected both groups the same because there was no difference between the two groups.
Yeah. Okay. I mean, you touched on the issue of the potential bias there already, so I don't have to address that. I've got two questions from two people there. Actually, the same questions from Rajiv Garg and from Ryan Hakimi. And they are: has this study had any influence on your own way you practice in your institution?
Well, I mean, I was involved in this practice over the entire course. Although I was blinded to the results, I spent a lot of time thinking about what the results might be. I also have to admit that I had some great professors, Larry Marshall in San Diego and Douglas Miller in Edinburgh, Scotland, and who were very critical and very analytical. And I guess personally, I've never really followed the one-size-fits-all approach to ICP. So has it affected? I think what it's done is it's made us more open in the discussion on rounds and with other people of liberalizing ICP thresholds and sort of violating quote-unquote magic numbers when we treat people. We've always kind of done this, but now we're making it more algorithmic and studying it more formally. So I think in that respect, in my own treatment, it's probably it's codified things more than originated things. But to some extent, you can see the influence of this study already in the literature. There was a recent publication from the Cambridge group about area under the curve versus the ICP number as a threshold from David Menon and Merit Shosnica, Jean Picard, Peter Hutchinson, and their data suggested that we're probably not looking at ICP itself right, but the area under the curve is probably more valuable.
I have another question here from Evert Erickson. I mean, although it's not part of the study directly, was a DVT prophylaxis started, and was it used? What was used for that in the groups, and was there a protocol for that?
Yeah, there was a protocol for DVT prophylaxis. They were using heparin because that's available and inexpensive. There were decubitus ulcers in these patients. Interestingly, the only statistically significant group difference not favoring ICP marker, there were the two efficiency ones that favored it, was there were more skin breakdowns, not severe, but low-grade skin breakdowns in the ICP monitored group than there were in the other group. Obviously, a reflection of the sensitivity of the ICP monitoring and its the ICP response to position changes. So interestingly, we didn't really expect that. We don't think that was true, but there was a difference. It didn't reflect in terms of length of stay or mortality, but there was a statistically significant larger number in the ICP monitor group.
I think we're approaching.
Yeah.
Go ahead.
DVT or PE. The DVT and PE rate were actually low, quite low. So, and they were pretty aggressive with that. 24 hours, they started DVT prophylaxis.
Okay, thank you. I think we're approaching the end of our webinar. If there's one more urgent question, I'll wait a few more seconds. And otherwise, this brings us to the end of our... oh, wait a minute, one last question coming in from Alex Axelrod. So after analyzing the results of this study, which arm of the study would you opt to choose clinically if hospitalized at a major U.S. center?
Oh, well, you know, to be perfectly honest, I would choose a center not based on this algorithm. I would choose a center that optimized my resuscitation and did excellent general critical care. Those are the condiciones sine quibus non of where I would choose. Beyond that, I want an attentive physician that takes good care of me. And then, you know, I think that we can use ICU modeling probably in the way we've always been using it, because we can dig ourselves out of any complications that we may result. But in general care, if I'm going to be cleared at, you know, a level 2 or a center that doesn't do traumatic brain injury every day of the year, I think we've got a ways to go. And I think that's where I think it'll make the difference. Most of all, I want a good pre-hospital care. I want a good intensivist. I want good nurses. Beyond that, I would prefer to be monitored. But I would also prefer not to be treated by someone who thinks of physiology and not magic numbers.
Well, with that closing sentence, I want to thank Dr. Chesnut for his informative presentation and commitment to improving TBI treatment. Thanks to all of you attending and participating today. We hope you will join us for our next complimentary webinar in early April. Keep an eye out for an invitation in your email box or visit our website at bezinscriticalcare.com. All the best and have a great rest of your day.